Okay.
Now it got.
Okay, sir.
Hmm.
So coming to spinal cord is a continuation of central nervous system. It starts at the lower end of the medulla, where C1, where this thing starts, and from there it goes up to L1, L2 level, where it ends as a tail, basically called as phylum terminal. Before that, we have a bunch of nerves that exit around the L1 level, forming a tail-like appearance that is called as a cauda equina. There is a bulge in the cervicothoracic level and in the lumbosacral level to accommodate for the motor movements of the hands and the legs respectively. So we have 31 pairs of spinal nerves that exit along the various exits of the spinal cord. So coming to cross section of the spinal cord, we have three major columns. That is the posterior column that consists majorly of the sensory input. The lateral column that consists of autonomic nervous system along with white matter tracts, and the anterior column consisting of anterior horn cells, Renshaw cells, and descending white matter tracts. So basically, I have just described what are the tracts that are like ascending and descending over here. So primarily, the ascending tracts include the fasciculus cuneatus and the gracilis and the fasciculus cuneatus. There is also spinocerebellar tract. There is spinothalamic, spinoreticular, spino-olivary tract, spinocerebellar tracts, etc. The descending tracts again, there are corticospinal tracts. There is the rubrospinal tracts. There is reticulospinal tract, there is vestibulospinal tract, and tectospinal tract. They serve to like involve in various functions of postural control, movements, flexor responses, etc. So coming to the blood supply of the spinal cord, primarily blood supply is through three arteries. That is one single anterior spinal artery and two posterior spinal arteries. So these arise from the vertebral artery at the craniocaudal level and descend downwards to supply the entirety of the spinal cord. In between, they also take tributaries, I would say, from thyrocervical trunk and the ascending aorta itself. So the major part of which is the T9 to T12 level, where we have radiculomedullary arteries, one of which is called as the artery of Adam-Kiewicz, one of the major suppliers for the anterior spinal artery. So coming to importance of the clinical history in a case of spinal cord. So clues to a spinal cord lesion in the history that includes bilateral sensory or motor symptoms in the limbs with sometimes concomitant sphincter disturbance being present. There might be, patients may say that there is stiffness in the legs along with some amount of spasm in the legs. There might be also associated weakness of the legs. So some of the symptoms that is peculiar to spinal cord is what I will discuss here. One of which is the Uthoff phenomenon. Uthoff phenomenon is one where patients with demyelinating disease, they develop recrudescence of symptoms attributable to a CNS demyelinating lesion, whereas increase in body temperature, like during fevers, after an exercise, after a hot bath, they produce symptoms that is attributable to this spinal cord lesions. So there might be other features such as there might be a feeling of a tight band present around the chest or a torso. So whenever this is present in cases of MS, it is called as MS hug. So there is one more phenomenon that is described. It is called as a Lermit phenomenon. Lermit phenomenon is basically an electric shock-like sensation or a tingling sensation that radiates downwards when there is neck flexion or neck hyperextension. So that is sometimes a clue to cervical myelopathy, but it might also be encountered in other etiologies also. So cord lesions can sometimes disrupt the phrenic nerves and cause diaphragmatic paralysis also. It is C3 to C5 levels that is majorly important. And thoracic lesions again can cause sensory symptoms or they might cause motor symptoms in the lower limbs. thoracic cord lesions can also cause autonomic symptoms because there is a presence of autonomic dorsolateral area. There is autonomic innervation also. So sensory ataxia, sometimes specific to PNS, but sometimes also seen in spinal cord lesions. So that is primarily in the dorsal column dysfunction. So what are the clues when we take history of neurological this thing that localizes to spinal cord? That is bilateral greater than unilateral symptoms of sensory and motor. There is bladder bowel involvement or associated sexual dysfunction. There is stiffness in the legs. There is neck and back pain associated with neurological symptoms. As I said, a proper sensory level if present. Presence of Lermit or Uthoff phenomenon. There is a neurogenic claudication. This is usually localized to cauda equina, also seen in canal stenosis also. Sensory ataxia, as I said, more specific to PNS, but sometimes seen in dorsal column dysfunction. And dyspnea when lying flat, especially in C3 to C5 lesions. So coming to time course of symptoms, again acute, subacute and chronic. So acute, it is traumatic and vascular. Traumatic goes to compressive, so we'll not like talk much about it. But in vascular, we have spinal cord infarctions, might be because of like an embolus, or might be a clot that is there. So subacute lesions, they are mainly demyelination and space occupying lesions. Chronic or progressive, mainly MS, hereditary spastic paraparesis, motor neuron disease, and metabolic myelopathies. So time course is important. So whenever we speak of acute, it is from days to up to 2 weeks. Subacute is 2 weeks to 6 weeks, and chronic is 6 weeks upwards. So spinal lesion, like on examination, what are the clues that we get to majorly know that it is a spinal cord lesion? So UMN signs majorly spasticity, hyperreflexia, presence of clonus, and pyramidal weakness, and a bilateral upgoing plantar response. Not unilateral. Unilateral may sometimes localize to the brain, but bilateral. So presence of paraparesis or quadriparesis. Whenever we are examining the reflexes, presence of inverted biceps or brachioradialis. Basically, striking on the brachioradialis causes pronation, but in this case, there is flexion of the fingers. In inverted biceps, normally there is flexion of the biceps, but in this case, there is extension of the biceps. This is basically because the level at which the transaction has occurred. So if it is at the level of C5, the lower, the motor neurons lower to that will be released basically. So that causes the exaggerated responses in those corresponding areas. So involvement of multiple contiguous dermatomes when we are checking for sensory levels, and presence of absent abdominal reflexes. This is not very specific because it can be absent in about 15% of normal individuals, sometimes absent in pregnancy, sometimes absent post-surgery. So this cannot be relied upon much. Presence of gait disturbances characterized by stiff legs, circumduction gait, scissoring of the legs, and sensory ataxia with positive Romberg sign. Again, spinal shock and neurogenic shock, and certain spinal cord syndromes, which I'll be discussing. So coming to basic classification, like how they classified initially was, if there was a subarachnoid or a subdural space compression, they called it as compressive myelopathy, and if there was not, it was called as non-compressive myelopathy. So coming to etiologies of myelopathies, we have again compressive and non-compressive. We'll majorly concentrate on the non-compressive part of it. We have infectious, we have vascular, we have demyelinating, we have presence of toxic substances and physical agents, we have degenerative, we have metabolic etiologies, and there is paraneoplastic etiologies. So we'll be discussing majorly of these things. So coming to infectious, primarily viral, bacterial, and fungal. We'll be concentrating more on the viral aspect of it. So some of the viruses that can cause transverse myelitis are herpes zoster, Epstein-Barr virus, cytomegalovirus, HIV virus, HTLV1 virus. So bacterial usually cause abscess and compressive symptoms. So we'll not be delving much into that. Coming to the demyelinating symptoms, some of the demyelinating disorders that can cause non-compressive myelopathies are primarily ADEM, MS, and NMO spectrum disorders. NMO spectrum disorders again includes neuromyelitis optica and MOGAD. Coming to vascular disorders, so vascular disorders again, spinal artery thrombosis can cause either anterior or posterior. So anterior spinal artery thrombosis usually involves the anterior 2/3 of the spinal cord, causing motor weakness and related disorders. Coming to vasculitis, sometimes lupus, Sjogren's, and sarcoid can involve the spinal cord, that we will be discussing in later section. Coming to toxic substances, there is latherism, there is something called as conzo, there is triorthocrysyl phosphate poisoning, there is nitrous oxide poisoning, radiation-induced spinal cord injuries, and electrical injuries. Coming to degenerative, there is primary lateral sclerosis, there is familial spastic paraparesis, there is spinocerebellar ataxia, Friedreich's ataxia, etc. Coming to metabolic, there is vitamin B12 deficiency, vitamin E deficiency, copper deficiency. There is renal disease or hepatic disease causing myelopathies, and there is hexosaminidase deficiency, and also, of course, associated paraneoplastic myelopathies. So if you see, majorly the first column, this is what causes acute presentations, and as we go down, these are what causes subacute and chronic presentations. So basic differentiation, how to differentiate between compressive and non-compressive myelopathy. There might be bony tenderness, bony deformity present in compressive myelopathy. There might be girdle-like sensation that is more commonly seen in compressive myelopathy. Root pains, more commonly seen in compressive myelopathy. And onset and progression, usually acute in non-compressive myelopathy. Bladder and bowel involvement earlier in compressive types of myelopathy, and in later stages also seen in non-compressive myelopathy. And it is more symmetrical in non-compressive myelopathy. As I said, time course, acute is within days to 2 weeks, subacute is 2 to 6 weeks, and chronic is more than 6 weeks. Phase is important because whether it is a monophasic or a multiphasic illness. So monophasic acute usually is seen in transverse myelitis, cases of ADEM. Multiphasic illnesses are usually seen more often in demyelinating diseases like MS and MO spectrum disorders. And again, extent, whether it is in one particular place called as monofocal or in multiple places called as multifocal. So coming to distribution, if it is only restricted to the gray matter, mostly seen in poliomyelitis. If it is restricted to the white matter tracts, it is called as leukomyelitis. If it involves one cross-sectional area, it is called as transverse myelitis. Transverse myelitis, again, partial transverse myelitis and complete transverse myelitis. If it involves the meninges along with the spinal cord, it is called as meningomyelitis. And if it involves meninges roots, it is called as meningoradiculitis. So some of the spinal cord syndromes that I'd like to discuss associated with non-compressive myelopathies. That is complete cord syndrome, where involvement of all tracts are seen. If there is a complete transection seen in acute transverse myelitis. Brown-Séquard syndrome, called as a hemi section of the cord. So that is most often seen in multiple sclerosis, sometimes seen in compressive symptoms or hemitransection of the cord. Anterior cord syndrome associated with anterior spinal infarct, multiple sclerosis, sometimes associated with operative clamping of the thoracic aorta, as I said, artery of Adam-Kevich's and branches. Posterior cord syndrome associated with metabolic, usually vitamin B12 deficiencies, copper, nitrous oxide poisoning. In some cases associated with infectious syndromes also, like HIV myelopathy. Central cord syndrome, again, more often compressive, seen in syringomelia, also sometimes seen in neuromyelitis optica spectrum disorders. Medullary cone involvement, conus medullaris, seen in post-viral myelitis. Cauda equina, usually associated with cytomegalovirus and polyradiculitis symptoms. And tractopathies, as I said, associated with B12 deficiency, multiple sclerosis, and paraneoplastic myelopathies.
So medullary cone, one unique involvement is MOGAD.
Okay, sir.
Conus syndrome.
Yeah. So some differentials when we are thinking of myelopathy, and if there is presence of peripheral neuropathy also, it might be associated with subacute combined degeneration, HIV associated myelopathy. Friedreich's ataxia may associate with peripheral neuropathy and spinal cord symptoms, and Tapes dorsalis seen in syphilis. Coming to inflammatory myelopathies, characterized by enhancement, post-contrast and gadolinium enhancement on MRI, and associated pleocytosis on CSF. So some of the conditions associated with inflammatory myelopathies are infectious in viral, bacterial, fungal, and parasitic, autoimmune, Sjogren, sarcoidosis, mixed connective tissue disorder, P-ANCA positive vasculitis. In demyelinating, MS, NMO, EDEM, post-viral myelitis, paraneoplastic myelitis, and encephalomyelitis. Coming to non-inflammatory myelopathies, they are majorly of 4 types, that is inherited, hereditary spastic paraplegias, inherited metabolic disorders. And in metabolic, vitamin B12 deficiency, copper deficiency, folate and vitamin D deficiency. AIDS-associated myelopathies are also non-inflammatory. Coming to toxic, cassava poisoning, latherism, fluorosis, and nitrous oxide poisoning. And vascular, it is anterospinal artery thrombosis and AV malformations. So this is basically how the flow goes. Whenever there is history and examination suggestive of myelopathy, we do an MRI, and MRI usually helps us classify it as compressive or non-compressive. If there is associated gadolinium enhancement, that like points us more towards the inflammatory cause. So once the type of lesion is characterized, then we do a CSF analysis. If it is inflammatory, there is also associated pleocytosis that helps us to identify whether it's an inflammatory or non-inflammatory lesion. So as I said, again, the gadolinium enhancement is important. And in some cases, if there is a multifocal involvement of the spinal cord, we can also do a brain MRI to see if there are other demyelinating lesions present in the CNS.
If you have MS, which is not active, yes, you may see MRI changes without enhancement also, isn't it?
Yes,
still
yes.
It will not be active lesions.
Yes, sir. So coming to a few patterns that are seen in MRI, central involvement usually seen in infarct and infective conditions. Peripheral enhancement seen more often in demyelinating conditions, in some cases of infections like HIV, HTLV1 conditions, and paraneoplastic. Diffuse cord involvement seen more often in infection and autoimmune conditions, also sometimes in dural AV malformations. Then irregular kind of a feature seen in more often with vascular conditions, more compressive like tumor, abscess formation, and trauma. So coming to imaging features and associated conditions, basically blood within spinal cord bright in T1 and dark in T2 signal. Sometimes like associated vascular malformations like cavernous angioma and dural AV fistulas, we have seen this. There are multiple loss of signal intensities in T2 usually. Flow voids within spinal cord, again dural AV fistulas. Central T2 signal abnormalities seen in venous hypertension. Ring enhancing lesion, again consider demyelinating infections or tumors. Fusiform lesions over more than 3 spinal segments called as longitudinally extensive transverse myelitis. Consider NMO spectrum disorders. Short segment transverse myelitis, like less than 2 spinal cord segments and less than 50% of cord diameter. So consider multiple sclerosis. So sometimes we find that clinical history and examination, we think of it as myelopathy, but MRI sometimes may be normal. In such cases, it can still be myelopathy. Like we'll have to be aware of these things. MRI findings not suggestive of myelopathy. If it is not a myelopathy, then it might be one of these two, like Guillain-Barré syndrome. and inflammatory polyradiculopathy. So sometimes MRI performed post the illness in the convalescence period might be normal. In cases of Friedreich's ataxia, in cases of motor neuron disease, where you have both UMN and LMN features, vitamin B12 and copper deficiency myelopathies early on may not be seen on MRI, and hereditary spastic paraparesis and HIV HTLV1 may not initially be seen on MRI. So coming to longitudinally extensive transverse myelitis. So as I said, extensive involvement of the spinal cord, T2 hyperintense lesions, at least involving more than 3 spinal cord segments. So some of the differential diagnoses associated, like typically seen in NMO spectrum disorders, but in some like in some cases of MS, confluent lesions can mimic longitudinally extensive spinal cord involvement. Immunologically, neurosarcoidosis, Behçet's, SLE can mimic longitudinally extensive transverse myelitis, paraneoplastic myelitis, post-infectious myelitis. Coming to CSF examination. So along with associated pleocytosis, we may see low CSF glucose concentration, usually in fungal, bacterial or mycobacterial involvement. Sometimes seen as low in neurosarcoidosis also, carcinomatosis meningitis and SLE. So CSF WBC count, as I said, it suggests inflammatory myelitis. So along with that, if there is presence of high IgG index in CSF along with associated oligoclonal bands, that means there is an inflammatory picture going on. So if none of these findings are present at the time of onset of symptoms, then MRI and LP can be repeated 2 to 7 days later to see if there is progression. So as I said, pleocytosis seen in infections and inflammatory conditions, and mononuclear cells present in AV malformation and paraneoplastic myelitis. Erythrocytosis again seen more often in vascular conditions and associated vasculitis. Protein elevation seen in tumor, paraneoplastic myelitis, vascular myelitis, etc. In radiation associated myelopathy, sometimes we may not see anything on the CSF. CSF picture might be normal. Presence of bizarre giant cells on CSF in the background of HIV infection suggests vacuolar myelopathy of HIV, and pronounced pleocytosis with normal glucose and eosinophilia is seen in eosinophilic myelitis, more often associated with parasitic infestations. So basic evaluation schema. So once we think the history and examination suggests spinal cord lesion, we confirm the time frame if it is acute, subacute or chronic, and then we do a MRI with contrast to rule out compression. So once the compression is ruled out and if there is presence of inflammation or non-inflammatory lesion as on gadolinium enhancement, we then consider non-inflammatory causes, do a spinal cord tap, confirm the presence of inflammation if it is there, and then check for the sites of demyelination in other areas like brain MRI that can be done. So now coming to proper discussion proper of non-compressive myelopathies. Acute transverse myelitis or ATM, usually female preponderant, biphasic peaks initially seen sometimes in 10 to 19 years of age and then usually after 30 years of age. Pyramidal symptoms along with a definite sensory level with some cases of autonomic dysfunction, backache and progressive paraparesis, like usually up to 4 weeks is the time frame that is considered, and band-like horizontal area of altered sensation on torso and sometimes in the neck, plantars, usually bilateral extensors. So there are inclusion criteria and exclusion criteria. Exclusion criteria basically excludes all other conditions like thrombosis of spinal artery, presence of dural AV malformations, presence of vasculitis as seen on MRI. So in the inclusion criteria, again, sensory motor or autonomic dysfunction present, bilateral signs, clearly defined sensory level, time period of between 2 to 7 days, nadir up to 21 days is what they consider. That's it. Coming to MRI findings, focal and central high signal intensities of T2 observed on T2 occupying more than 2/3 of the spinal cord axially extending over 3 to 4 segments, generally in the thoracic spine. Spinal expansion may or may not be found, and in general, there is contrast medium enhancement. So in 40 up to 40% of the cases, MRI findings may be normal also. So this is a case of a 22-year-old man who presented with features of progressive paraparesis, and on evaluation there was longitudinal extensive transverse myelitis. Based on MRI, we can just comment whether it is a transverse myelitis, and the extent of transverse myelitis, the time course of progression, and evolution in space and time that defines whether it is a restrictive lesion or it is a progressive lesion. Coming to majorly in transverse myelitis, there is a background of post-viral illness that has elapsed, or there might be a background of vaccination. So a development within days to 2 weeks is seen. There is a monophasic temporal course. Once the symptom occurs and there is progression up to 3 weeks, and then subsequent resolution occurs, there will not be a subsequent reoccurrence. So 40% give positive history of infection of EBV, CMV, and mycoplasma, but not Clostridium jejuni infections basically. And slight asymmetry of symptoms and signs, sensory level on trunk, and unilateral Babinski positive, like bilateral Babinski positive, distinguish it from GBS. So coming to investigations, CSF WBCs, pleocytosis may be seen, normal glucose, protein may be elevated, post-inflammatory in some cases. Majorly in this, we consider like absence of oligoclonal bands. So minimal gadolinium enhancement with slight T2 signal abnormalities over 2 to 3 spinal cord segments. So post-vaccination myelitis seen in smallpox, hepatitis B, influenza, rubella. Coming to infectious myelopathies. So when do we suspect spinal cord infections? If there is demographic factors suggestive of residence in endemic areas such as West Nile myelitis, history of exposure, basically high risk behaviors, blood transfusions, chemotherapies, immunosuppression, and transplant recipients, again immunosuppression, CMV and HHV7 associated. So clinical clues, presence of lymphadenopathy, retinal lesions present in cases of CMV, pharyngeal involvement present in EBV, involvement of lung with lymph nodes in Cryptococcus and TB, presence of vesicles on the skin in HSV and enterovirus cases, like presence of erythema migrans seen usually in Lyme myelitis. So basically the types of viruses that involve in myelitis. So HSV, picornaviruses, dengue viruses, orthomyxoviruses, and bacterial, fungal, and parasitic, usually they cause compressive type of symptoms characterized by abscess formations, etc. So coming to specific features of viral myelitis involving particular parts of the spinal cord, we have enterovirus and Coxsackie viruses. We have enterovirus and Coxsackie viruses involving motor nucleus, herpes of dorsal root of ganglion, and extensive inflammatory necrosis of spinal cord, schistosomiasis, as I said, eosinophilic myelitis, HSV2, sometimes associated with distinctive syndrome of recurrent sacral chordaequina neuritis with urinary retention with associated outbreak of genital herpes. This is called as Ellsberg syndrome. So disturbance of function in either sensory or motor neurons rather than tracts are majorly seen in viral myelitis. Sometimes tracts are involved, that is most often seen in cases of HIV1 and STLV1. Associated zoster also sometimes presents with chordaequina myelitis, and sometimes rabies, the dumb variant, can present with tract involvement. Okay, coming to HIV myelopathy. HIV myelopathy is primarily a diagnosis of exclusion. So pathologically, we see there is vacuolar myelopathy with spongy degeneration and demyelination. There is symmetric, painless, spastic paraparesis. Lesions usually more often seen on the dorsal cord. They sometimes resemble SACD, but B12 levels are normal. And these lesions do not usually respond to highly active antiretroviral therapy. Coming to HTLV1 tropic spastic paraparesis, slow progression with UMN signs present, Early bladder involvement is seen, preserved brainstem and mentation, posterior column involvement with corticospinal tract, primarily in the thoracic cord, and CSF associated normal proteins and glucose with sometimes presence of HTLV1 antibodies. Coming to syphilis, multiple presentations of syphilis in the spinal cord, TAPes dorsalis associated with syringomyelia, meningomyelitis, pachymeningitis, vascular syphilis. So, posterior columns and spinal roots are predominantly involved in non-compressive symptoms. So, these are characterized by three phases. One is pre-ataxic phase, characterized by lightning pain in the legs, tingling sensations, Argyll-Robertson pupil, and urinary incontinence. Ataxic phase characterized by sensory ataxia and slapping gait, and paralytic phase characterized by progressive paralysis. CSF shows pleocytosis, protein elevation with CSF increase in IgG and oligoclonal bands. Demyelinating diseases, again acute disseminated encephalomyelitis. This is majorly coming into demyelinating picture. Usually monophasic, and it is unifocal, resolves and it goes off. So sometimes it is confused with initial part of the MS where the space and time evolution has not occurred. Monophasic picture of ADEM may confuse with the initial presentations of MS. So history of preceding viral or infectious illnesses are present. So diffuse demyelinating lesions that are usually of the same age. Unlike MS, the lesions are of the same age, present monophasically but in multiple areas, so multifocal. So ADEM symptoms include rapidly progressive encephalopathy along with seizures and multiple neurological deficits. Spinal cord affected in about 11 to 28% of the patients, generally in the thoracic and cervical segments. So ADEM is suspected when there is multifocal presentation with multiple symptoms. Patient age is somewhere around 10 to 19 years. Signs and symptoms suggestive of meningoencephalitis, presence of bilateral optic neuritis, CSF pleocytosis without oligoclonal bandings. With oligoclonal banding sometimes seen in 65% of the cases. MRI shows lesions in areas not affected by MS, such as the gray matter or the cortex. Lesions on the MRI are larger and poorly defined edges that enhance with gadolinium. Coming to multiple sclerosis, as I said, short segment areas, multifocal and multiphasic, like dissemination in space and time is present. Presence of Lermit symptom, sometimes seen in MS. So in some cases, the patient may be asymptomatic, but the MRI might still show presence of lesions. As Sir said, like if it is not a very active case of MS, that can happen. So primarily, McDonald's criteria is what we consider dissemination in space and dissemination in time. So space, one or more lesions in with or without gadolinium enhancement in two of these following areas, that is periventricular, juxtacortical, infratentorial, and the spinal cord. So time, one new lesion on T2 sequence that is gadolinium enhancing when compared to the previous MR image, with concomitant findings of asymptomatic lesions with or without enhancements. So coming to investigations, again OCBs are present. IgG index is more than 60%. Subclinical optic nerve involvement, usually on visual evoked potential testing. Even if there is like optic neuritis, it will be usually on one side. It is not usually bilateral. Advanced neuroimaging such as diffusion tensor imaging and magnetization transfer imaging can help identify the involvement of apparently normal white matter that is usually seen abnormal in MS and it is normal in ADEM. So MRI findings, plaques may be anterior, central or posterior. Unlike neuromyelitis optica, viral or idiopathic myelitis, in MS no black holes are visualized on spinal cord. So N-acetyl NAA is been found reduced on spectroscopy and in spinal cord areas that appear normal on conventional MRI. So this is the case of MS. Here we can see T2 short segment involvement. So that is usually diagnostic of MS, along with dissemination in space and time, that is characteristic. So neuromyelitis optica, lesions are centrally located and necrotic. So usually longitudinally extensive transverse myelitis is seen. More common in Asian and African individuals, and like differentials such as SLE, Sjogren's, and thyroid autoimmune disorders sometimes may coexist with NMO. So diagnostic criteria for NMO, it is called as Wingerchuk criteria. So there is optic neuritis associated with acute myelitis, and at least 2 of the 3 supportive criteria, that is contiguous spinal cord MRI lesion over 3 vertebral segments called as LETM. Brain MRI does not satisfy diagnostic criteria for MS, and NMO IgG is seropositive. So combination of optic neuritis with myelitis can also occur in other associated conditions like MS. MS, as I said, unilateral optic neuritis associated with spinal cord lesions. ADEM, bilateral again optic neuritis with spinal cord lesions. Sjogren's syndrome, SLE, and paraneoplastic, mainly that antibody to CRLP5 can be seen as a differential diagnosis for optic NMO spectrum disorders. As I said, MRI findings, LETM, T2, mainly T2 sequence, and post-contrast T1 gadolinium patchy enhancement is seen. So in 60% of the patients, periventricular lesions is seen. That is where we have these aquaporin channels. So primarily concentrated over there. So NMO is not associated with cerebral white matter lesions, and spinal lesions are usually confluent. And cranial nerve and cerebellar involvement are common in MS, and they are not usually present in NMO. Coming to MOGAD, it is similar to NMOST, but MOG associated disorders, lesions are more confluent. Like it is LETM, but it is more of a cotton wool kind of an appearance that we see. And MOG IgG associated disorder patients also usually have conus involvement. And on axial sequences, lesions are usually central. Recurrent isolated LETM is rare with MOG IgG associated disorder. Gadolinium enhancement is not very frequent in MOG. That we have to keep in mind. Gadolinium enhancement may be seen in MS, like in active lesions. NMO, it is definitely seen. It is usually not, like it is not seen on MOG associated disorders. So with treatment, MOG disorders lesions usually resolve completely. So some of the MRI features comparing MS in pictures 1 and 2, NMO in pictures 3 and 4, and MOG in pictures 5 and 6. So if you can see, there is a short segment T2 hyperintensity that is enhancing on gadolinium post contrast T1. Here there is a longitudinally extensive transverse myelitis that is again enhancing on gadolinium post contrast T1. Here there is a longitudinally extensive transverse myelitis, but there is no contrast enhancement as seen on gadolinium. This is MOG. Again, similar picture. So coming to brainstem, I'll be very brief about this. So usually unilateral on MS, there is optic chiasmal involvement with periventricular involvement on NMO spectrum disorder, and there is usually bilateral optic neuritis with predominant involvement of nucleuses, gray matter nuclei in the brainstem in brain in MOGAD. So again, differential diagnosis of inflammatory myelopathy. I'll not go into detail. I have already discussed.